The one type of pain that Dr. Lou cannot help with is traffic pain. It is awful in this city. How is my favorite chiropractor there, Captain Crunch? How are you doing this morning?
I'm pretty good. I'm actually here. I'm in the parking lot. But I guess you do this first segment in the car. Yeah, the Gardner and Lakeshore were a bit of a mess this morning.
Yeah, it is good times for sure. So we're going to be doing a bunch of stuff today. How was the week, by the way? Now that you're paying for your parking, good.
Very good. One interesting case that I had this week that I wanted to talk about was, I don't want to get into the case too much. I'd rather talk about the outcome of the case. So I had a lady that gave me a call, and she was asking me about a chronic pain issue that she's been having. And she's basically tried everything that she could from a physical perspective.
Right.
And so, I'm big on, and not because I'm big on it, but because the research supports it, that pain is multifactorial. There's a physical component, but there's also a psychological component. So I started talking to her about, if you've tried everything from a physical perspective, then the only way that you're left to intervene is potentially from the psychological aspect. And she was a little bit offended with that. And she said, I don't think that's fair that you're saying that I'm just making that up. And I said, okay, well, let's start from square one here. I'm never suggesting that the psychological component of pain means that anybody is making it up. All I'm simply stating is that pain, everything you do in life is interpreted in your brain, and that brain sends out a signal.
Mm-hmm.
And therefore, pain works the same way. It's the interpretation of what we feel that creates in our brain the perception of pain, which then is sent out to our body. It's a response. And obviously, if you have heightened emotions or any other type of psychological issues, because that's the area where all of this is getting integrated, it can be compounded. And that's why things like distraction and focusing on other things help so well when people don't feel well. And I've heard it a ton of times, and I'm sure many of our listeners and maybe even you, John, have experienced that. If you're not feeling the greatest, but for whatever reason you get distracted because you're talking to somebody or you're in the middle of doing something, you don't really tend to notice your pain.
Yep.
Or what? And the reality of that is just simply because you're distracting your brain, because that shows the psychological component of the pain perception and how we perceive pain. So one big thing that I really wanted to try to talk about today is understanding that pain has two components that we can work at from. We can work at it from the physical perspective, and we can also work at it from the psychological perspective. And now Each one of those is broken down into other subcategories, such as the physical perspective may mean like the biochemical perspective, such as medication or a surgical component or manual therapy or exercise. And then on the psychological side, just understanding the human experience of that individual helps us to understand how they integrate pain. And when they've looked at research to look at chronic pain and what's often associated with chronic pain, two things that they consistently find is a history of depression and poor sleep. And that kind of makes sense because, of course, if you're in pain, you're going to have some type of depression. And, of course, if you have depression and pain, it's going to make it harder for you to sleep. And so it becomes this vicious circle where oftentimes where I meet people that have one of those things and you start talking to them, they also have the other two. It just goes hand in hand, and the research supports that.
It's pretty interesting stuff, and that'll be kind of the focus for the first part of the show today. We'll take a quick break, let you run inside here, get in studio rather than hanging outside with the common surf. So we'd love to have you in here. So we'll take a short break. The number to call through, by the way, 416-870-6400, star 640 on cell. Would love to get your opinions. You have questions about pain or anything bugging you in the physical or otherwise. Dr. Lou is here right to 1 o'clock. It is the Dr. Payne Show. Just getting warmed up right here. Talk Radio, AM 640. Dr. Payne is here indoors now, much more comfortable than talking in your car.
That was pretty nice in there.
It was,
actually.
right? Yeah, just the traffic's not, that's all. Jays game, that's why what's going on there. Because they're doing well. We're doing better on this show, that's for sure. So, yeah, pain and the thought process and the mental component, yeah?
Yeah, for sure. And one of the best ways that I try to highlight this aspect of the psychological perspective of pain is phantom limb pain, which we've talked about, quite a few times, I would say, on this show already. And for those of listeners right now that haven't heard us talk about it, phantom limb is essentially when somebody has lost a limb for whatever reason, and they can still feel some type of sensation in that limb that's no longer there. And that could be in the form of cramping, an itch, pain, et cetera, et cetera. And what phantom limb pain highlights is the fact that although the physical perspective of your body is missing, that although these people will say, if they're missing their left leg and they have pain in their left foot, they'll say, I feel it in my left foot, even though their left foot is not there.
Neural pathways, right?
Neural pathways, that's right. It's the exact same as when we learn to ride a bike. Initially, it's a motor pattern. It's very, very hard. And then after a while, you cannot ride that bike for 10, 15 years. You get back on it, boom, that neural pattern still exists. And it's the same thing with pain. As you think about, and that's why the longer you experience pain, one of the things when patients come in to see me, a question we often get is how many treatments or how long will this take to get better?
Right.
And one of the things that always changes person to person, injury to injury, et cetera, et cetera. Mm-hmm. But one thing that I can tell anybody is that there's no quick fix when you've had pain for a long time because of that neural pathway component. So chronic is often defined. There's some discrepancy, but after 3 months, 6 months, some research even says after a year. I think it's about after 3 to 6 months where that chronic pain component really starts to set in. And when you've had that component going on for so long, what essentially happens is you start creating so many neural pathways for that pain. And one of the areas where we see this a lot, I have a patient right now who was hurt in a car accident, and this person. It was a pretty bad accident, but their pain is not getting better. And one of the reasons their pain is not getting better is because they've had to leave work. So they're off of work. And all they're really doing is staying home, focusing on their pain. Sometimes returning, even if it's not returning to work, because some people can't return to the work that they do, finding something to stop that pathway, because the more you keep thinking back and forth about that pain, all you're doing is creating that pathway, and it creates that vicious cycle of, I can't forget it. It becomes all-consuming. And that all-consuming type of an effect just makes it amplified. It makes it worse and worse and worse. And so it's often a thing that we have to work with. But anytime something's been going on for too long, the treatment response is never going to be easy, just by the very fact that there's the mental component now in play. That pain is being created. There's pathways that are being created that can't easily be forgotten.
And it takes time to unlearn or relearn.
That's right.
To get away from it, right?
Yeah, and that's the whole process. And in some instances where the chronic pain has been going on so long, it's kind of like, think about, could we make someone forget how to ride a bike? Right? Probably not. Those neural pathways exist. All you can do is teach them how to not activate those pathways.
Right.
How do you stay away from that? That's where, the psychological side of things, the cognitive behavior therapies that I've talked about a lot about, that's where the real benefit for those things are, because they teach you how to take your pain and your perception of your pain and change it. Because once you can change that perception, that's the power right there. That's when you can really have a big effect. And it's so interesting because, and, in the last 10 years, we've seen that mental health is becoming more accepted, because there still is a stigma around it for whatever reason. I'm not sure why. But there is still some type of stigma around it. But it's so important because it plays into everything. And that doesn't mean that you have to have a severe mental health issue to experience pain. But those two can go hand in hand. And as I said, when you look at the research, it is not uncommon to see that those who have chronic pain are also suffering from depression. And that just shows you how integrated it is. Also because it's all integrated in the same place in the brain.
416-870-6400, star 640 on cell. It's funny, you mentioned riding a bike, and it reminds me, I saw a show last year sometime, and what these people did, and it speaks to what you're talking about, the way the pathways are made. They take a bike, and where the handlebars go down into the fork, so, normally you get on a bike, you go right, bike goes right. You turn the handlebars left, you go left. They had a swivel, so it would do the exact opposite. So you turn the handlebars right, the bike goes left, and nobody could ride this bike. And the guy who created it took him months and months and months to get his brain used to the fact that when I turn the handlebars to the right, my bike is going left. But then once he learned it, he had to unlearn it to get back in a normal bike. It was fascinating.
And that's the whole process. And how do you teach new neural pathways, right? And so that's where you don't necessarily forget the old ones, but you can teach yourself new ones. And I think that's a great example. That's exactly the types of things that we try to do in multidisciplinary pain management. That includes a psychological approach where you're trying to teach people the distraction techniques, the new things that they can learn. A lot of cognitive behavior therapy is focused around people have, let's take, for example, public speaking, which is one of the biggest fears around.
Huge.
People often, when they've looked at this, the fear is that people are often afraid that they're going to be ridiculed. That's their biggest fear. When you sit with a psychologist, what they actually make you do is, is go through, okay, what are your beliefs about it? So you think you're going to be ridiculed. Then the reality about anything, you have to face your fear in order to get over it. And so cognitive behavior therapists will recommend now go public speak, but actually document the facts, right? Does anybody actually ridicule you? No. People, a lot of people.
What actually happens?
What actually happens?
I've done it. It's great.
So what are you thinking versus what actually happens? And it's the same thing with pain. I see people so many times that I've said, okay, I need you to bend down and touch your toes so that I can see the range of motion in your low back. And they have that chronic pain presentation and they say, I can't bend. It's like, but you haven't even tried. Right? Why can't you bend? Oh, because I'm afraid it's going to hurt. Okay, well, let's try it. Let's give it a shot. And then they go through it. Okay, that's not so bad. Exactly. That's where you have to try to change what your preconceived belief is and turn it into what the reality is.
Once you get your hands on them, is there also a medication factor that you have to overcome too? Maybe they've already been through it long enough where now they're getting on pills. You got to get them off that as well.
Yeah, well, when you look at most of the chronic pain medication is often the same medications that they'll use for depression because it's supposed to be the same type of idea where you're trying to stop the psychological input. The problem with those things is often it just kind of numbs you out versus focusing on the problem, on the solution of solving that pattern behavior problem where you have a certain preconceived notion. It does depend. Medication does play its role when it's needed, and then at other times it's not needed. But that's like anything, right? Sometimes massage therapy plays its role, and other times it doesn't.
Get to Ahmed here in Brampton. Hey, Ahmed, how are you?
Hey, not bad, doctor. So I got I don't know. I mean, I've been going to my family doctor, but I just want to get your opinion on this. About six years ago, I was coming out of the shower and with the Q-tip, I was cleaning my ears, and I don't know what I was thinking. I started using the Q-tip into my belly button. Next day I woke up and there was blood on little bit of blood, not much, on the thing. And then after that it got maybe infected. It was very, the odor, it was very nasty, but it was gone away. So I was like, okay, whatever, it's gone. But every now and then, after like 6 months, sometimes even sooner, I get this abdominal pain, and sometimes the fluid comes out. So I've been to my doctors. They've given me they've given me the antibiotic, and the other times, they've given me some sort of poly. I don't know the name. I can't remember right now, top of my head, but something to go in the belly button so it goes away, but it keeps coming back. I'm not sure if I need to, is there anything can be done with this, or? Well,
it does sound like whatever you did on that day created some type of trauma to the area. And at best that I can tell from talking to you, it just sounds like it's never had the chance to heal properly. Right. So I think whatever efforts you're focusing on should be towards the healing process. Now, I don't know exactly what you've done in order. How long has this been going on, Ahmed?
It's been actually, 4 or 5 years, but it's not like it comes and goes. So I'll fine for 3 months, maybe 6 months. Then all of a sudden, maybe, sometimes, go to the beach with the kids swimming after a long, when water goes in there. My doctor was saying that your belly button is quite deep. So maybe, moisture stays in there. And even though I try to clean it after shower and stuff, but still.
Yeah. I mean, again, that's not really my specialty, but it does sound to me like it's something that just has never had the chance to heal properly. And because it's never had the chance to heal properly, it's prone to constant infections. And it really is like anything. It's even like kids that have chronic ear infections. They're common to have more chronic ear infections. So, any area of the body that has some type of trauma, it's more common to experience injuries and other things in that area of the body.
We'll take a short break. Phone lines wide open. Got some calls if you'd like to make them. We'd be here to answer until 1 o'clock this afternoon. 416-870-6400. Star 640 on Cell. Dr. Payne Show, Talk Radio, AM 640. And your free consultation as well. Call that number anytime. Get the pain management happening. 416-870-6400, Star 640 on Cell. Got some open lines. We'd love to talk to you this afternoon. Right now on the Dr. Payne Show. And Fred, good afternoon.
Hey, good afternoon.
Good.
I guess I injured my back a number of years ago, and the pain was extreme. I couldn't cross the room by myself.
I hear you.
I mean, it was totally debilitating. And I remember thinking that, if I had to save my child from a fire, I couldn't.
Yep.
I couldn't do that.
Mm-hmm.
And I went through the regimens of treatment and that. But one of the things I did was, and I didn't know back then to call it what you're calling it, this cognitive
CBT
stuff.
Yeah.
And you'll try anything at a certain point. And I would just tell myself that, the pain isn't there. Just ignore it.
Yep.
It's like a loud radio on the wrong channel or something like that. Ignore it.
Mm-hmm.
And it took a long time.
Yes.
But eventually, I started to get some relief from it.
Mm-hmm.
You can't do anything for a sudden stabbing pain that catches you unaware. But that chronic, that ongoing thing, I was able to push it down over a long period of time.
Yeah.
So when I heard you talking about it there, I didn't have words. I didn't have words for it or anything like that. What it would do, but it does work if you focus on it. If you've got a real pain and it's over a long period of time, and you focus on it, you can achieve relief.
Mm-hmm.
Especially if you're strongly motivated.
Yeah, and Fred, the point that you're highlighting, that it takes a long period of time, even if had you done it professionally, I think it's great that you somehow figured it out on your own. And some people do figure it out on your own, but even done professionally, it takes a long time, and it's one of those things that can't be stopped. You have to keep practicing that type of mentality in order to get over it. But you're absolutely right. It is something that if you can try to distract yourself, focus on other things, diminish how important it is to your life, it does have a way of making it better. It's just the reality. Like when I try to explain this to some people, they say, well, I don't know if I believe in that. And they use terms like that. It's like, there's nothing to believe in.
Yeah.
Your mind is the motherboard for your body. It controls literally everything. Hence why when you're in a vegetative state, there is no pain, right? One of the things that a neurologist checks for to see the level of someone's coma is pain, right? Can the person, and they will literally take their knuckle and rub it against their sternum. And if you did that to anyone, they would just
yelp,
or even on their shin, and that would kill. But when you're brain dead, when you're in a vegetative state, there is no pain. That's why oftentimes people will say pain is kind of a vital sign, similar to blood pressure and to heart rate, because of the very nature that if you feel pain,
you're alive.
You're still alive. If you're not feeling pain, there's a big problem there. And so, pain does have a perspective. It does, from an acute perspective, it's very important. It helps us to remove us from danger. That's its premise. But over the long term, for sure, if you're focusing on it, and some people just become their own worst enemies with it. They don't want to accept this approach that you need to find a way to diminish its importance. And Fred, I'm glad that you're an example of someone that was able to find that out on their own and help yourself. Because, and one of the things I always say is to even my team, and one of the things my first clinician ever said to me was, you can only help someone as much as they want to help themselves. Mm-hmm. And that's so true. And I'm glad that you were able to help yourself that much, Fred.
Well, thank you. It's good. I would have, considering all the professional advice I was getting at the time, it would have been nice for someone to give me a booklet or something on it, because I was just trying it out of desperation. And frankly, when I started the exercise, I just said, I would lie to myself and tell myself I don't feel the pain. Mm-hmm. But with practice, it became a reality. But I didn't know that there was a technique.
Right. Actually, Fred, if you're interested, read The Brain That Changed Itself by Norman Doidge. He goes through a lot of this stuff, and then he's taken work from other people. So if you're interested in more readings, you can look at the sources that he used. But I think that would be a great read. And for anybody out there that's really interested in trying to understand the way the mind works, keep listening to the show week after week. But read the book, The Brain That Changed Itself from Norman Doidge. Great book, highlights all these things that we've talked about, whether it's the phantom limb or, the OCD issues, the depression issues. It's so important. It highlights exactly what the name says, the brain that changed itself. You do have the power. Everybody has the power that with your mind, with your thoughts, you can get better 100%.
And with that, phone calls, if you have an opinion, have any questions on this topic or others, call us, 416-870-6400, star 640 on cell. Dr. Payne Show, Talk Radio, AM 640. It's 12:32. We got open lines, 416-870-6400, star 640 on cell. You have pain concerns, health concerns, bring them on. Dr. Lou's here to answer them. You know, it's funny you mentioned that person trying to get them into the behavioral therapy, and they say, I don't believe in it. Well, it's not really belief, it's behavior.
Oh. Yeah.
Right?
Yeah, 100%.
Belief.
It's so funny with healthcare. So many people say these things to me. I don't know that I believe in that, which that belief, why they don't get better, highlights the power of their mind, because your mind works both ways. If you believe you can get better, you likely will. But if you have the belief that you can't, the same is true. It's the whole reason why the placebo effect exists, right? You're given something, someone tells you it's going to be. It's even, they've done research where it's even the disposition of the practitioner that you work with. Now, our job as practitioners is to be honest with people, but there's a way to be honest where you could say, you do have this, but you can get through it, versus saying, oh, that's really bad, I don't know that you'll get better. Or saying, yeah, no, 100% you're going to get better, I guarantee it, right? You don't necessarily want to be on the 100 guarantee page, because you can't really guarantee healthcare. And you also don't want to absolutely say, no, there's nothing that can be done. But giving some type of hope is very, very important. And the placebo effect is extremely important. There's even Sir William Osler, who was a renowned physician and now has a whole healthcare system named after him, often said that any practitioner that doesn't use the placebo effect to their advantage is an idiot. Why wouldn't you want to use something that helps you get better? Even when people have said, oh, I think it helped, but I think it's because I believed it was going to help, so I don't know. It's like, well, what's the difference?
Yeah. Are you better? If
at the end of the day you're better, what is the difference? That is the whole outcome that you're looking for. And remember, it goes the other way. If you're doing an intervention, I've had people that, we recommend, okay, we need to start you on a course of physiotherapy or whatever. And if they start doing it and they say, I don't think this is going to work, already right then and there, I'll say, you know what? If you don't think it's going to work, we're not even going to start this, because you could be providing them with the very best care. But if they already have that preconceived belief of it's not going to work, chances are it's not going to work because they have that belief. So you don't necessarily want to stop them. But then I sit with them and I try to educate them and tell them, like, listen, anything that you do have to have a component of wanting it to help you and believing that it can help you. And whether that's surgery, and there's even outcomes with surgery. One interesting study that was done for arthroscopy of the knee was, when you get some scoping done in the knee, they often put little slits to slide the scopes in.
Yep.
What they had was two groups of patients. One group of patients actually had the surgery, so they had the slit scopes put in and debris was taken out. Other group of patients had the slits, but never any scoping.
No intervention.
So then when they woke up, the only thing that they knew was they saw scars. So they believed, yeah, I had a scope done. And their outcomes, both groups, exactly the same. They both improved the exact same amount just by the very nature that they believed they got the surgery.
416-870-6400, star 640 on cell. John, good afternoon. How are you, pal?
How are you, sir?
Good. What's your concern?
I don't know if it's the cause of a couple of accidents I was in car accidents, but I get these massive headaches, and you could be sitting there, there's no problem, I feel okay, and then bang, they just happen. And I've been pronounced dead twice, which obviously I'm still living. But my doctor will not give me any medication, because of the opiate thing and everything for the pain. So I take acetaminophen with the codeine in it, and it's just as addictive.
Yep.
Yeah. Well, for sure. Yeah.
And I remember I listened to Coast at night on your station, and
good show.
Yeah, it is. It's a fantastic show because they get the best people there is. But this one guy, I caught the show right at the end, and he was just screaming. He was a doctor, and he was screaming, "Stay away from the acetaminophen."
Okay.
So without it, I don't have anything. Aspirins do nothing at all.
Right. Yeah, I mean, again, I'm of the belief that every single thing that we have to our exposure in terms of medicine, therapies, etc., all has its role, and sometimes acetaminophen is absolutely needed. Now, anything, one of the things that you highlight is anytime you use something for a long period of time. It's interesting how many people I've talked to that say we're talking about depression. It's like, oh, I'm on an antidepressant. Well, are you still depressed? Yes, but I still take the medication. Or, I'm on a pain med. Do you still have pain? Yes. So, it's funny. They continue using something that was given to them that's not necessarily happening. Or, yeah, I'm doing physio for my shoulder injury for the last year, but I'm not better, but I still do it, right? And it's like, well, why are you continuing an intervention that doesn't necessarily work is one question. But yeah, no, acetaminophen does play its role. I mean, oftentimes between the things like aspirin, Advil, Tylenol, personal preference is a big deal. Also the belief, right? Those are medications that we're often exposed to even as children. And so, I remember when I was a kid, my mom always would say things like, oh, Advil doesn't work for me. Tylenol is what works for me. So she would use Tylenol. Right. So by the very nature, anytime we needed something, she gave us Tylenol. And so that has that sociological environment perspective plays a role in those things. Your issues, John, how long have they been going on for?
Oh, for years.
Okay.
Years, really, since
and tell me a little bit about your headaches. Where are they exactly?
They can be over the whole,
okay.
skull on top.
And have you noticed what brings them on?
No, because I'm not doing anything. I'm just sitting here listening to talk radio and feel fine. And then all of a sudden, whack, it just comes on. And
okay. So one important thing to remember when I ask people, what makes it come on, and it's not uncommon to hear what you just said, which is, oh, I'm not really doing anything, but maybe not doing anything is what makes it come on, right? And so my question is, what are the things that you've done? Whether doing doesn't necessarily mean you have to be running or doing something. It could just be that you sit, and maybe the way your posture is when you're sitting is eliciting the headaches, or maybe when you sit down to listen to talk radio, your head is slightly turned to the left. Like, that's the important thing about headache diaries, is trying to figure out exactly what it is you're doing that is eliciting these headaches. And so already if you're saying, usually when I sit and listen to talk radio, I'm getting headaches. Maybe it's talk radio. John Scholes may be the problem.
Totally.
For your
100%.
Actually, it can happen anytime.
Anytime, okay.
I was watching TV and I'm comfortable on the couch.
Right. But one common feature there is you're sitting, right?
Right.
So maybe do your headaches come on if you're out and about and moving around? Like,
yes.
Yeah, they still tend to come on?
Okay.
Yeah.
Yeah. So again, that's the tricky part with headaches, is always trying to figure out exactly what brings them on. This is where try to document it, right? Grab a diary, start today. You get a headache, write down the date, write down what the temperature's like outside, the things that you've eaten,
your posture, everything.
Your
right?
posture, what you were doing at the time. A few hours before, what led up to it. And then what happens is over a long period of time, after a few weeks, months, you get a professional look through that and you start looking for common features where it's like, well, here's something that's popping out. And a lot of the times it's trial and error, right? So we may very well decide, okay, you know what, it seems like sitting, for example, even though it may not be the case for you, is what's setting it off. So be careful. Let's limit your sitting to, less than 10 minutes at any given time, et cetera, et cetera. So it's all trial and error. But, the other thing is what we were just talking about is trying to diminish the importance of the headache in your life.
The one thing where you have to go is through that tube. Is it the MRI, that thing?
The MRI.
Yeah. Well, I think we're going to take a break and we can discuss
we'll hang
MRIs after that.
Hang on for a sec, John. We'll get right back to your phone calls as well. 416-870-6400, star 640 on cell. Taking your calls right till 1 o'clock. The Dr. Payne Show, Talk Radio, AM 640. Yeah, your phone calls, 416-870-6400, star 640 on cell. Sorry, John, had you on hold there. MRIs.
No,
let's discuss
fine.
that. Sure, buddy. Hang on.
Yeah, John, you were speaking about MRIs. Anytime long... So usually the indication for any type of imaging, whether it's, for your spine, your extremities, your head, is if something is going on long term, more than, 4 to 6 weeks, then yeah, it is an indication to see what exactly is going on there. Mm-hmm. MRI would be probably the best option to look at the brain. It's not going to, if there's a benign cause to your headaches, for example, a migraine type of component or a tension type of component, that won't be picked up. What MRIs do is pick up things that are serious pathology, like a cancer, a neurodegenerative disease, things like that. So hopefully, there's nothing like that. Also, before you jump to those things, a lot of those types of serious causes to headaches have other clinical signs that a good practitioner can pick out with a good physical exam. So, MRI is definitely an important imaging to consider with anyone with headaches, depending on the length of time they've been going on and the other associated clinical signs and symptoms.
Hey, there was one thing I just want to say last. I'll do it quick.
Sure.
I went in for an MRI. You drink that drink, and it didn't work. It didn't show up at all on my body. So I had to go sit outside in the waiting room, half an hour. They gave me the drink again. It doesn't show up at all.
And that was for your brain?
For everything. Like I have Crohn's.
So they were probably doing some type of digestive study.
Yeah. And so they took me down the basement of the hospital, and you wouldn't believe it. It was just like Frankenstein, Dr. Frankenstein. You never seen such old X-ray machines in your life. Honest to God. But yeah.
They took you to Area 51, eh?
Yeah. But the one of them worked.
Well, there you go.
Yeah, well, that's the key, as long as one of them works.
It's a quality piece of equipment. It's like the Corolla of X-ray machines.
Yeah, exactly.
Helena, how are you?
Hello.
Hi.
Hi. In 2009, I had been diagnosed with cancer. They removed my left breast.
Mm-hmm.
And now I cannot stand the pain. And my doctor has sent me for ultrasounds, MRIs, and everything. And every time I bend over, I fall on the floor. The pain is so severe.
And it's in that same area where the breast was removed?
Yes.
Okay. It's definitely anytime surgery is involved and you start removing any type of tissue, all tissue has certain nerve innervation. And so once you start cutting away things, you start to damage nerves. And in damaging those nerves, there's going to be a pain syndrome. And pain due to post-cancer and post-operative things is even more difficult to deal with. And I've had a couple people with similar issues where, a breast was removed and then they have excruciating pain in there. And the best advice that I can give there, and it's not even, going to solve the issue completely, but it goes back to how we started this show. If you can't tackle pain from its physical perspective, because that's the problem in that area once you've had things removed, it's going to be very difficult to intervene from a physical perspective, then intervening from the psychological perspective with some type of behavioral therapy where you try to diminish its importance in your life, try to distract from it, et cetera, may be another option that you may want to consider.
And what's the other options?
Well, that's what I'm saying. If from the physical perspective, there's limited options with that type of issue, and you can't intervene from the physical perspective, then intervening from the psychological perspective is the other option.
Have you ever tried any of that, CBT?
The pain is so bad, I can't stand it.
Yeah, well,
and that's what I mean. Trying to work with a professional who can help you from a psychological perspective, try to diminish that pain. It would be of some benefit for sure.
Okay, thank you.
No problem.
Yeah, it's tough. It's just tough to get that initial over the hump to get try the CBT, right?
Yeah, and again, and you could tell even from that caller, it's just really hard for people to accept that the mind plays a role in pain for whatever reason, and people are. And it's always a hurdle to try to get over and explain exactly its importance. And again, anytime I've ever said this to anybody, whether it's my patients, people listening, this is not me saying that you're making it up, that, it's in your head, like, you're just thinking about it. No. I'm just simply saying that the brain is your motherboard. It integrates what you feel and sends signals back out to your brain.
That's why you feel pain.
And so
your brain.
Let's innovate in the motherboard, right? Like let's innovate that way.
We'll get to Kathy quickly before we break. Good afternoon, Kathy.
Hi.
All right. What's your concern?
Well, my concern is I had a Baker's cyst, and it's in the back of the knee, right?
Yep.
And I'm a fairly athletic person, and it's really it's been awful for me because now when I'm walking, the pain is unbelievable. The cyst has gone down. My doctor gave me naproxen, 500 milligrams. Okay. And that really did bring the cyst down. However, I had the MRI, and they now say the cartilage. She says you just need an injection likely. So I've been put on the waiting list to see the orthopedic person.
Okay. How old are you, Kathy?
I'm 58.
Okay. Yeah. So what a Baker cyst is so let's start from understanding the knee. The knee is the meniscus is the cartilage in between the femur and the tibia. There's synovial fluid in that joint. What synovial fluid is like kind of like a WD-40. It's what lubricates the joint. As things start to degenerate, as we get older, or you are very active or whatever, and that cartilage wears down, as that cartilage wears down, that synovial fluid starts to seep out of the knee and can create a cyst called the Baker cyst, which is in the back of the knee. Oftentimes, the Baker cysts are pain-free. It's just an incidental finding where, fluid is forming and it's in a cyst. And it only really becomes relevant if it starts impinging on structures, whether it's the muscle, the sciatic nerve, et cetera, et cetera. But definitely if your cartilage is worn, that shows an indication as to why the synovium is seeping out. I would have to see the extent to which your cartilage is worn in those problems. If you're ever interested in a second opinion, one of the clinics that I have, I actually have a few surgeons that work alongside of me specifically dedicated to knee surgery, and we could maybe see what they think of your issue.
Kathy, here's a number for you, 1-855-55-Dr. Lou, DRLOU. Again, 1-855-55-Dr. Lou. Get a consultation happening for yourself, and in the meantime, you want to call the station. You got a few more minutes here to get through. 416-870-6400, star 640 on your cell. Dr. Payne Show, Talk Radio, AM 640. And right back to your phone calls here, 416-870-6400, star 640 on cell. Lynn, good afternoon. Thanks for hanging on. How are you?
I'm okay.
Good.
I have a question for Dr. Lou.
Sure.
Okay. What is likely to cause a maxillary artery to crack in the facial region close to the nose?
To crack?
Yep.
What do you mean by crack? Like repeated, like popping noises, or it actually ruptured?
Last October, I had a bad bleed, and it was a maxillary artery, apparently, that cracked.
Wow. Yeah, well...
And I was lucky, apparently, that they found it.
Yeah. Well, the maxillary artery is very important, and it supplies, the area of your face on whatever that side where it's coming off of the carotid artery.
Right.
So what makes a crack? Anytime an artery cracks or ruptures, that's actually termed a hemorrhage, right? That's why people that have strokes could either be a clot that stops an area of an artery getting blood, or you can have the opposite where the artery actually opens up and blood spills into the head and there's hemorrhaging. So it's a similar type of thing. You had hemorrhaging in that area. And your question is, why would that happen?
Yeah.
Sometimes it's just a weak point. And a lot of times when they've seen people, you can even look at, sometimes you'll see it on x-rays, and it's an incidental finding with the abdominal aorta where you'll see that there's a bulging in it. Sometimes prolonged high blood pressure, for whatever reason, can cause that type of thing. And other times it would just be insidious, idiopathic. We don't know why it happens. So, and that's probably the more likely answer is you'll never know. The good thing is that you caught it and that you're okay, because again, that is a pretty main artery. And, you need to stop any type of hemorrhaging anywhere.
Okay.
Yeah.
Thank you.
No problem.
Appreciate it, Lynn. We'll get to Nancy. Good afternoon, Nancy.
Hi, yes. I was just calling about, I injured my back about 15 years ago. I fell down the stairs, and I've been in chronic pain ever since.
Okay.
I've had every test that you can imagine. I've seen every orthopedic surgeon, neurosurgeon, sports doctor, acupuncturist, all of it.
Okay.
And I'm still just stuck on pain meds.
Right.
Is there any, new things? I guess what has happened is.
So Nancy, have you tried? Yeah, have you tried anything from the psychological perspective, like we've been talking?
I did.
Okay.
I have. I went to a clinic, and it helps. I mean, I'm still living my life.
Yep.
I work full time. I teach part time. I have a huge family and an active life, but I'm still in constant pain.
Yeah.
And it's exhausting. It's a bit depressing. It's hard. It's hard to live with pain for 15 years.
And your issue is clearly complex. What I would suggest, what's probably a better option is we can maybe connect off air. Just because I see there's a lot of calls coming through. I want to try to get it to everybody. But give me a call. Leave me a message with your contact, or I'll have your contact from the call screener, and I'll give you a call, and we can talk in depth about it, because, again, there's probably a lot that can still be done.
Angela, we'll get you in here. What's your concern?
Hi there. I've had multiple accidents, multiple surgeries. Most recently, I had a Brostrom Gold technique done on my left ankle.
Mm-hmm.
And I've been on disability for almost 2 years, also with mental health issues. And I've been told over and over again how pain relates to, your brain. And I've been told to do hypothalamic exercises to help with the pain. I'm just wondering if, because of my history, like I said, I've had other surgeries and other problems. I had bunion surgery at age 12. I had dislocated hips at birth.
Mm-hmm.
Who I should be seeing. I've been looking at Ehlers-Danlos as a possible diagnosis, but I've just been wondering if I should be seeing a pain clinic or a rheumatologist, what my next step would be, because still in a lot of pain.
Yeah, the specialty that you see often is predetermined by what the issue that you have is. So rheumatologists tend to deal with a lot of autoimmune diseases versus, a chronic pain doctor will deal more with the mechanical types of pains that may be long-term. So same thing, let's connect off air and have a longer discussion. And for anybody listening out there, because I see there's a lot of calls coming out, and I just want to highlight this point. At any point in the week, 1-855-55 Lou, call, hit option 2, leave me a message, your name, your number, when a good time to contact you is. I'll get back to you within 48 hours, and we have discussions.
Again, we've kind of run out of time here this week, but again, just to reiterate, info@paincarecanada.com. You want to get a hold of Dr. Lou, and like you just mentioned, 1-855-55 Dr. Lou, DRLOU, anytime. Get that free consultation happening. Start getting better with that phone call. The Dr. Payne Show till next weekend, right here, Talk Radio, AM 640.